Well, students, coming to the today's topic, that is drug interactions. What is an interaction? Interaction is said to be when the effects of the drug is changed by presence of other drug. That means drug-drug interactions because of other drug or other herb or phytochemical or food or drink, whatever it may be. It has some influence on the drug. That is the interaction between drug and drug. That is drug-drug interactions. And the drug interaction is defined as the pharmacological activity of one of the drugs that should be altered by the usage of another drug. That means by the presence of some other substance. The drug whose activity is affected by such interaction we call it as object drug, and the agent who precipitates such interactions that we call as precipitant. There are different types of interactions. One is, as we talked before, drug-drug interactions, and next one is drug-food interactions, where the ingredients in the food will interact with the drug and it can induce the effect on such system. That is drug-food interaction. And next one is chemical drug interactions. When you consume or when we see or consume any chemical, that chemical go and binds with that particular drug and inhibit or can control the activity of the drug. That is the drug chemical interactions. And if you see the drug laboratory test interactions, while performing any laboratory test, the drug may interact with such type of compounds, and these are called drug laboratory interactions. And drug disease interactions, we can walk through the slides and we can discuss further. An interaction that occurs when pharmacokinetics or pharmacodynamics of a drug are changed. These are all kind of interactions, and most probably the causes are the multiple prescribers. That means the doctor is prescribing more number of drugs, that leads to the drug-drug interactions. And multiple pharmacies, a lot of companies are making different kinds of drugs with different formulations. It may lead to the drug-drug interactions. And also the genetic makeup. Nowadays, personalized medicine has come into advancement. That means based upon our genetic influence and genetic makeup, the drug is designed. That is personalized medicine. And if you see some specific populations, like the female population, that means that that particular gender related proteins, the hormones, and based upon the age, that means elderly persons, and based upon the obesity, certain hormones are produced at the time of puberty and menopause, like that. And malnutrition, because of the malnutrition there might be malfunction of some of the systems. If certain enzymes are required for producing particular enzyme or for producing certain metabolites, there may be non-requirement of this kind of nutrients. In that case, it leads to adverse effects. And critically ill patient and transplant recipient. Transplant recipient, he might be aware of he might be exposed to some kind of immunological response. In that case also, it is one of the causes that may lead to drug-drug interactions. And specific illness, such kind of hepatic disease, that means kidney disease and renal dysfunction, and also narrow therapeutic index drugs, like such as if you take cyclosporins, digoxin, insulin, lithium, antidepressants, warfarin, etc. These kind of drugs which can show the drug-drug interactions with other kind of drugs. If you take the mechanism of drug action, it could be divided into two types mainly. One is pharmacodynamics, one is pharmacokinetics. The pharmacokinetics, it involves the effect of a drug on another drug kinetics. This includes ADME properties like absorption of the drug, distribution, how it is distributed in our body, and metabolism, how the drug is metabolized by our enzymes and metabolized by liver, processed by liver, and excretion, how the liver and kidney are eliminating the remnants of the drug from our body. That is the pharmacokinetics. And coming to the dynamics, pharmacodynamics, dynamics is the action. That means how long your drug is interacting with your protein, your target protein, and target enzyme or target tissue, whatever it is. The pharmacodynamics related to pharmacological activity of interacting drugs, such as synergism, antagonism, whether it is agonistic or antagonistic your drug. That means it is altering the cellular transport, that particular effect on the receptor site. Next, the net effect of the drug interaction. That is generally it's quantitative. It means the net effect may increase or sometimes it decrease. And if you monitor this situation, drug interaction, it is seldom qualitative. That means a rapid or slower effect. If you consume the drug, if you take the drug or a pill, it is showing a rapid effect. In the case of ENO or something, it has to show the rapid effect. And in case of insulin, it has to be long lasting, that it has to show the slower effect. Then is precipitation of newer or increased adverse effect. Next, when considering the pharmacokinetic interactions, these interactions which show ADME properties, as we discussed, absorption, distribution, metabolism and excretion, these are the properties of the drug, and it should be alterated by precipitant. So hence these interactions are called ADME interactions. That means these are also can be classified into absorption interactions, distribution, metabolism and excretion interactions. And if you consider the absorption interactions, it mainly include the alteration in gastrointestinal pH and alteration in gut motility, inhibition of gastrointestinal enzymes, complexations, adsorptions, and alteration of gut microflora. And in rare case it is malabsorption syndrome. If you consider the alteration in gastrointestinal tract pH, the non-ionized form of a drug, that is, the drug is more lipid soluble. If you consider the lipophilicity, the drug should possess lipophilicity as well as hydrophilic properties, and it should be more readily absorbed from gastrointestinal tract than the ionized form does. Some drugs are absorbed from stomach. So when this media becomes neutral or alkaline, this will affect the absorption of drugs such as sulfonamides. And if you take aspirin, such as some antacids, it leads to enhanced dissolution. Some drugs like ketoconazole or tetracycline, and with the antacid, if you take this with the antacid, it decreases the dissolution. Okay, next, alteration in bacterial flora. How the drugs alters the bacterial microflora. Bacterial microflora has a remarkable role in metabolism of some drugs. Long-term antibiotics may kill normal flora and adverse drug absorption. If you take antibiotics, it has a broad range of activity, a wide range of activity. It kills large population of intestinal microflora, which could really beneficial for our microbial biodata. And it increases the digoxin concentration and chance of toxicity. If you see tetracycline and some fluoroquinones like ciprofloxacin, if you take with the antacid, or if you consume the food containing divalent ions, it leads to the formation of poorly soluble chelating agents. That means complexes that cannot be absorbed. And if you take cephalexin, sulfomethoxazole, warfarin and cholestyramine, it leads to reduced desorption, and this is due to the binding. And it can also, some of the drugs may alter the gut motility. These drugs usually alters the gastrointestinal tract by emptying time, by altering the peristalsis of the gut. Hence it leads to the defective absorption. If you take aspirin, diazepam, it was co-administered by metoclopramide, and that leads to rapid gastric emptying and increased rate of absorption. And if you consider the malabsorption syndrome, such as vitamins called vitamin A, vitamin B12, digoxin with ribomycin or collagen, it leads to inhibition of absorption because of the malabsorption. If you consider the phenytoin, it's a highly bound drug to plasma protein, and tolobutamide and warfarin, these are the drugs. These drugs are displaced. These drugs can replace the agents like valproic acid and sulfonamides. If you consider the metabolic interactions, the effect of one drug and the metabolism of other is well documented in the literature. The liver is the major site of the drug metabolism, because it processes all the drug, it controls all the drug activities and processes and eliminates from the body. But other organs also can do. If you see the scavengers of the body, the white blood cells always do, and skin and lung and gastrointestinal tract, these are the major sites which can do the metabolism of the drug. If you consider the CYP450 family, it is a major metabolism enzyme. Whenever your drug finds a suitable substrate, suitable binding site, and it binds to the CYP450, immediately this CYP450 eliminates the drug from your body. And also the hepatic metabolism, it can occur in two phases, phase 1 and phase 2. Phase 1 is modification and phase 2 is conjugation. If you consider the CYP450 family, it has some isoenzymes CYP3A4, CYP2D6, CYP26, 2C8. These are kind of enzymes which actively participate in metabolism, and a drug may induce the change. It can induce the enzyme that responsible for metabolism of another drug. Suppose if you take oral contraceptives, that prescription drug is barbiturates, and it influences the decreased plasma level. This is due to decreased efficacy of object drug, and a lot of drugs like theophylline, cyclosporin, and oral contraceptives. It also can decrease the plasma level, leading to decreased efficacy of object drug. And most common than enzyme induction, the enzyme inhibition. This interaction decreases the drug metabolism and so increases concentration in serum, and it takes 2 to 3 days. Suppose if you take the drug folic acid or alcohol or pheromone rich food or coumarins, the prescription drug is like phenytoin, disulfiram, and cimetidine. These can majorly influence the fatal risk of hypersensitive crisis, and it enhances the metabolism and also increased chances of anticoagulation. There are a lot of severe adverse effects. And excretion interactions. Most drugs are excreted in urine or bile. Some drugs are reabsorbed from renal tubules and it enters in recirculation. Some drugs are excreted in acidic urine, and it affects the pH. The pH will affect the serum level. The major mechanisms of excretion interactions are alteration in renal blood flow, alteration of urine pH, and forced diuresis. Pharmacodynamic. When coming to the pharmacodynamic interaction, it means alteration of the drug action without change in its serum concentration by pharmacokinetic factors. They occur when the effects of the drug are changed due to presence of another drug at the site of action, either directly or indirectly. These may be direct or indirect. There are two types: direct pharmacodynamic interactions and indirect pharmacodynamic interactions. And antagonism. The interacting drugs have opposing actions. Example: acetylcholine and noradrenaline have opposing effects on heart rate. And addition or summation. The interacting drugs have similar action, and the resultant effect is some of the individual drug responses. Example: the central nervous system depressants like sedatives and hypnotics. Like if you consider the synergism, it is an enhancement of a action of one drug by another. If you take the example alcohol, it enhances the analgesics activity. And indirect interactions like salicylates decrease the ability of blood platelets that can aggregate and impairing the homeostasis. Warfarin induced bleeding occurs. Like if you take food drug interactions like grapefruit juice and terfenadine, grapefruit juice and cyclosporin, like tetracycline or fluoroquinones, like ciprofloxacin. If you take with the antacid or food containing divalentynes, lead to formation of poorly soluble chelates. And the consequences of drug interactions are major is life threatening. And if you consider the moderate, the deterioration of the patient status, and minor is very little effect. Reducing how could you reduce the risk of drug interactions? You have to first identify the risk factors which is contributed to the patient's health, and thorough investigation of the drug history of the patient. Sometimes it will be very helpful in resolving the case history of the patient. And you should be knowledgeable about the actions of the drugs, how these drug affects and what time you have to take, and consider the therapeutic alternatives. If it is giving the adverse effects, and you have to consider the alternative therapy in the form of allopathy or homeopathy or Ayurvedic, whatever it is. And always avoid complex therapeutics regimes when possible, and always educate the patient, and you should be in monitoring therapy. These are the resources which we have gone through this talk list, drug interactions 9th edition. And you can see the online drug interaction checker always while you are doing any kind of research, or if you want to take any drug, you can go through these reference websites, and these are the references and take.